cadre who are retiring.
Yeah.
It does. It shaves about 10, 15 minutes. So, yeah. Okay. But it requires everything to line up. The orange line. Right. Yeah. Log it away there. And then you just add that. She's coming back. Yeah. Well, while the yellow line was shut down, they had shuttle buses running. But the thing is, it took a while. And it was nice. It was a real, cool, chill, you know, just sit in nice air. You are the only person.
Yeah, when you retired,
I mean, the only thing I didn't care for was,
much less full time. Oh, okay. That's smart. That's a nice office.
Like, that was like half day. Great. Yeah. And then, leaving was no problem, because I knew exactly what to leave. Always left. Okay, well, I think time. But when you got back to La Plaza and caught up to go home, I mean, when you showed up, you went to the party, you need not line up, so you could get it. It was always there, but you might get there just before that, get there for a minute. So you know, I probably could have stayed on the blue line and maybe just earlier, but I just find the bus is more comfortable. Leg room, even the ability to.
I used to go to Crystal City. I would take like, I don't know, take the yellow line off the
I didn't see coffee. I saw coffee mugs. I don't think I can see it. I sit next to you.
Hello. That perfect. All right. Hi, folks. My name is Erin Tannenbaum. I am the WSS president and senior statistician at NORC at the University of Chicago, based in Bethesda, not to be confusing. Today's talk will begin in just a minute. I just wanted to give folks a chance to settle in and also mention a couple upcoming events that are also sponsored by WSS. So after this event, there will be a reception that follows. And then in June 21st, you guys are getting the save the date first and foremost, that the Cox lecture will happen starting at 4 p.m. with Rebecca Hubbard. And the annual dinner will follow at 6 p.m. again on the 21st at Carmine's. We also have the APOR WSS Preview Review Conference. That's scheduled for July 28th. A call for abstracts will be going out next week. For those of you that are available and interested in presenting, I encourage you to do so. This is the second time that event will happen after the pandemic. First time that this event is happening after the pandemic, so it's really nice to see everyone here. Also, I'll mention that if this is your first time interacting with WSS, please consider volunteering with us. We're a great group. A number of us are in the audience that volunteer and make these types of events possible. So come to me afterwards, reach out to anybody that you know that's within WSS. We'd love to have you as part of the team. Okay. All right. So let's go into the talk itself. Appropriate use of administrative data continues to be an important topic for statisticians, and today's talk is on the use of electronic health data, a topic that is near and dear to my own work. And welcome, David. I look forward to today's talk. Dr. David Marker retired from full-time work during COVID and continues to consult for CDC and others. He is a fellow of the American Statistical Association and American Academy for the Advancement of Science, and an elected member of the International Statistical Institute. In 2022, he received the ASA's Founders Award. A longtime member of the WSS, David served as its president in 2003-2004. And this talk is based on work he's doing for CDC with Georgia Tech Research Institute. With that, I welcome David.
Thank you, Aaron. It's a very nice honor to be here. Thank you, Mathematica Policy Research, for hosting. We, for many years, had a home at the Bureau of Labor Statistics. WS is kind of homeless now, so it's nice to have people stepping up to welcome us. And it's very nice to be asked to give the President's Invited talk. I was trying to remember back, I think when I was president, Andy Kohut of Pew Research is the person I had as the President's Invited speaker. This is often one of the talks I'd always circle to make sure to go to, even if I didn't know the speaker or the topic. It was just, many of you may be choosing it that way. But I hope you'll find this very useful, very interesting. So as Aaron just said, there is just a lot of pressure to use administrative data. A number of you have that as your job in government statistical offices, to sometimes instead of or to help with surveys, because we know that administrative sources, they're quite possibly cheaper. They're definitely faster to get access to than doing a survey, but they also may be less accurate. And that's what I want to look at here. Just as one example, last year, the chief statistician of Canada was quoted as saying, "It's no longer enough to conduct surveys and look in the rearview mirror at what happened. Citizens expect near real-time information." So that's the pressure that we're under. The outline of my talk is to talk a little about possible sources of big data, describe something called the law of large populations, and the impact of the correlation between response propensity and the value that is being measured. Then I'm going to focus in on using electronic health records, and within that in particular, the version of EHRs that's maintained and available from the National Institute of Health called All of Us. But from that, I think we can draw some real conclusions about the range of sources of electronic health records and the limitations thereof. The work has been under a couple grants from CDC, and I'd like to thank my co-researchers, Debbie Rolka and Rachel Kaufman of CDC, and John Duke, Charity Hilton, Richard Boyd, and Jacob Zelko of Georgia Tech Research Institute. So one of the first examples of using administrative records that I'm aware of, I guess the term administrative records could have to be defined, but using big data that wasn't collected, purpose collected for a survey, was looking at retail prices in stores. And historically, the economic prices were measured through a survey of thousands of businesses, where you'd go to the business and you'd collect all of those prices on the shelves. It became more electronic over time. But there's an alternative, which is to scrape the web. You can get data on millions of businesses very easily, and you can look at websites, you can look at advertisements. It's quick and it's inexpensive. But then you have to start thinking about, do all businesses advertise on the web? Do the corner bodegas and the gas station quick marts, do they all advertise on the web the prices they're having? And if they don't, then your estimates could be seriously biased. And it's not kind of a random bias, because the people who access these tend to be people who are poorer, have less options, and that's what's going to be missed. So there's a real perniciousness to that potential bias. So in the last few years, I've had a number of chances to delve into the world of electronic health records. And EHRs have millions of measurements on at least hundreds of thousands of participants. So this is a mixture of all the stuff your doctor, when you're talking to your doctor and they have their face in the computer and are typing away, All that information they're putting in there. It's also potentially test results. It's list of medicines that you are on. It can be the cost reimbursement claims data, all of that. I don't like this term, but it is getting to be used more of calling it real-world data. I noticed that at JSM in the program for this time that term is catching on. There's a lot of real-world data that has nothing to do with health, but they mean it in terms of health. But anyway, so with such huge data sets that are not nationally representative, not even state representative, and let me take a moment about the state representative comment. If you look at EHRs, what they tend to be, what's available from them, is conglomerations of different healthcare practices that have agreed in one way or another to share their data. But the healthcare practice may all be in Northern Virginia, and yet it says it's Virginia data. They may not have anybody from Southwest Virginia. They might not have Tidewater. Maybe they have Richmond. So even though they have lots of data, it can be very geographically concentrated. So a leader at the Census Bureau a few years ago raised an interesting question. He said, we all know that a 5% random sample is better than a 5% non-random sample. But is it better than an 80% non-random sample? How many people think an 80% non-random sample would be better than a... Inside information from census comes out here. How about greater than a 90%? Raise your hand. 95%? Few of you. How about if you had 99%? Oh, come on. How many of you just think it's a tricky statistical question? I mean, most of the time, I would think that if I had 99% of the population in my data, even if it's non-random, it's almost assuredly going to be better than a 5% random sample. I can make up an example when it's worse, but for the vast majority of the time, I think that's fine. And probably even 95%. I remember years ago, so Jennifer Parker's our discussant, your head of research and methodology at NCHS, and years ago, Monroe Sirkin had that position. And I did a project with Monroe where we were looking at combining survey data with RDD surveys. And the issue was that the RDD surveys didn't cover the 3, 4, 5% of the population that didn't have telephones. And so we were looking at how biased from the National Health Interview Survey you knew people with telephone versus not telephone. And there were some characteristics like smoking for which the bias was really strong. But for the vast majority of them, having a sample of 97%, a biased sample, was going to be okay. So this is a slightly different issue, but we keep having to address these problems in new settings. So I gave a first version of this talk last summer in Brazil, and I got data from them that's kind of similar, which was what percent of the healthcare facilities have access to electronic health records, which is a kind of a way, it's kind of the first step. Before you get to who agrees to get in this conglomeration is who even possibly has electronic health records. And overall, it was 88%, but you can see in the brown columns that it's a good bit higher in private than in public doctors' offices, and that there's regional distribution. Interestingly, there, when you think of like Rio de Janeiro and Sao Paulo, that's in the south of the country, and the poorer parts are in the north. So in the south and center west, you have over 90% coverage or possibility of EHRs, but in the northeast, it's only 81%. Kind of think of flipping the country from the U.S. kinds of states. So Xiao-Li Meng introduced this idea of a law of large populations in a paper in the Annals of Applied Statistics. So this is not the law of large numbers, the central limit theorem, but this was trying to look at what happens with large data. And if you've never heard Xiao-Li speak, I strongly encourage you to. He's been the head of the statistics department at Harvard, co-founder of the Harvard Data Science Review. He's often giving talks at JSM, and I heard one on this that got me started to be thinking of it. So he pointed out, closer? Okay. Don't often get told to be louder, but okay. So he pointed out that you can show that the mean square error of the sample mean is a product of three components, three factors. And the first one he called the data quality. It's the correlation between the response propensity and the variable being measured. The second, the data quantity, can be written as 1 minus f over f, f being the sampling fraction. And that corresponds, a little simple math, to capital N, the population size, minus the sample size, over little n. And the third, the problem difficulty, is the standard deviation of the thing you're measuring. Okay, so looking at these in reverse order, the problem difficulty is just if the data are more variable for a given sample, it's going to be less accurate. The sample is going to be less accurate, right? We know that the variance is related directly to the sigma. The data quantity, this n minus n over little n, is not the same as the finite population correction, where you have a cap n in the denominator, and it's always less than 1. Because if the sample size here is, let's say, 10% of the total population, 10% of cap n, then this computation shows you get a factor of 9 from this. So like the FPC, this goes towards 1 as you get big, but it can be very large and can have a major impact on the accuracy. And then the data quality, the correlation with response propensity, is on order of 1 over cap n only if it's a probability sample. So the key is that when it's a probability sample, these last two terms basically cancel out. One is of order n and one is of order 1 over n. And so that's why in all of our training as statisticians, we only focused on the first term, the standard deviation, because we were assuming we had a probability sample. But if we're going to look at big data at administrative sources that are not random, we have to consider all three of these terms. So he looked around at, unfortunately, to be able to estimate this correlation, you have to know the truth. And so there are limited circumstances where you have that data. But you can just do some theoretical circumstances. So he showed that if the correlation is 5%, is 0.05, and you get half the population, well, the effective sample size is like a random sample of 400. So if you have a big data source with 130 million American adults in it, half the adult population in the US, the same equivalent of a random sample of 400 if you have this level of correlation between the response propensity and what you're measuring. So kind of did a sensitivity analysis on that. Well, what happens if it's only 0.04 instead of 0.05? It gets you up to 625. Not much better. If correlation is 0.05 and you get 80% of the population, so that's over 200 million Americans to provide their data, that's like a random sample of 1,600. So let me explain what we mean. The n effective here is not quite the way we've used it before. But when you get a really large sample, you get a really small confidence interval on it, right? Because the sampling error is so small. And if you want a confidence interval that actually is going to have the true value of the population 95% of the time, that confidence interval has to be bigger. And the question is, how much bigger does it have to be? and what size sample does that correspond to? So because the bias can get you away from that answer, you have to have a pretty large confidence interval to have 95% coverage, and that's how he's calculating what the effective sample size is. So trying to see what it's equivalent to. A real-world example that he provided was in 2016. There was a series of election surveys done before and then follow-up with people, about 65,000 people across a number of states in the U.S. And they looked to see whether, these were web-based panels, to see whether there was this correlation between being in the panels and who you were going to vote for. And it turned out for Clinton, there wasn't really much of a bias. They got the right representation. For Trump, there was a small negative bias. Notice this is 0.005. This is 1/10 the numbers I had before. There's a much smaller bias than in the calculation we had before. But that bias was enough that there was this consistent underestimate of Trump's turnout, and the impact is worse in bigger states because you had bigger samples. So you thought you were doing so much, had much more accuracy that you didn't. There's a follow-on paper, the second paper that gives the background to this. And this was looking at COVID-19, the vaccine uptake in the beginning of 2021. So this is a paper in Nature magazine. I have the references at the end of the talk. And it compared 3 web-based sources that tried to estimate what % of Americans were getting vaccinated. And this was something we needed quick information on. So Facebook asked people to tell them whether they had gotten vaccinated, and they reported every week on 250,000 Americans. Census had recently started its Household Pulse experimental survey, and they had 75,000 respondents in every one of the data points. Being census, they did a better job of follow-up, trying to get people to participate. And then Axios and Ipsos had a poll of about 1,000 people, all of these based on web surveys. The truth we measure because the Centers for Disease Control got estimates from doctors' offices and state public health departments and all that, but it took a little while. They weren't nearly as fast as these 3 sources were, but we can compare it against them. So as I said, Facebook was a much less intensive recruitment effort. Please participate. That was about it. For weighting this, they all had age and gender for people. Census and Axios also had race and education to use in their weighting. But Axios also had political affiliation in urban-rural. I think it's a general rule, maybe even law of the land, that Census can't ask religion and it can't ask political affiliation. So, as you know, they're hamstrung in this case because, as we found out, whether or not you got vaccinated was highly correlated with your political affiliation. And Census has no way to adjust for that. So this shows the 3 data series. The blue is the Facebook estimates. Every one of those little triangles is a estimate based on 250,000 people. The green is the census estimates, and the red are the Axios Ipsos. You can see on the red ones that there's a vertical column. That's the confidence interval, a 95% confidence interval. On the green ones, if you have good eyesight, you can see there's a smaller confidence interval around that. And the gray are CDC's estimates of the truth. And as we can see, that once you get past January and February, Facebook is way overestimating, Census is overestimating, and Axios Ipsos holds the line until about April, when they are getting off by a little bit. All right? So what I want to do now is look at those 3 different components of the estimates to see what's happening here. And I apologize for the next slide. It's taken from the Bradley paper, but we'll go through it one part at a time. It's just very busy. So on the left is what you just saw on the previous slide. B in the top center is the bias, the absolute bias. It's the mean from little n compared to cap n again being CDC's estimate. And you can see for the blue that for the last few months, they're having a bias of between 15 and 20%. Their estimate is off. That's not a relative bias. They are off by 15 or 20%. The green, the census, was down under 10%, but the last couple of estimates are up, I don't know, 13, 15%, and Axios is much lower. The shading there is, well, CDC isn't perfect in its estimate. No apology to Jennifer. So it might be off by 5 or 10% in its estimate. So the dark blue is if CDC's estimate moves by 5% one way or the other, and the light is the light blue is if it's off by 10%. But you can see how biased those estimates are. C is the estimate of the correlation between, before it was G, here it's Y, what we're estimating, the percent with COVID and the response propensity. And you can see for the blue from Facebook, we're up at around 0.007 or 8. So that's higher than that 2016 example with Trump and Clinton. There's more bias here. In D, we have down at the bottom center, this is the quantity, the square root of n minus n over n part. And here, the only one that's not basically zero is the Axios Ipsos because it's a small sample. So this number is big, but when you multiply part D by part C, the red basically drops out because up here it's really small. So that's what we were saying. When you have a probability sample, which after all of that, the weighting that they were able to do is pretty close to it, those terms drop out. And then the last part, E, is the standard deviation. And as we know, as the proportion who have the characteristic, in this case, the vaccine, gets closer to 50-50, the standard deviation gets larger. So that's why it's harder for everybody in the last part. So what does that say about the effective sample of these three samples? The Axios Ipsos has a nominal sample of 1,000, and for the first couple of months, that's about what they had as an effective sample size, but it had dropped down to about 200. This is a log scale on the vertical axis. The census in green, 75,000 in every one of these point estimates, but while it had been a couple hundred early, the latter estimates are much smaller effective sample size. And for Facebook, with 250,000 in every point, even the first points were like a random sample of 100 in terms of accuracy, and it dropped down. So when you actually calculate in May what their effective sample size, Axios Ipsos was effective sample size of about 200, Census was about 15, and Facebook was 10. From asking 250,000 people, but not being able to adjust for all the sources of bias that it has. So this is the warning that that Xiao-Li Meng and Bradley and these others were pointing out of what's out there. So, and what's really driving it is the weighting here. So again, Facebook, just age, sex, Census got a lot better by adding race and education, but you really needed political affiliation if you're going to be checking on COVID-19 things, unfortunately. So the question is, what does that say about other kinds of applications? And what it's really saying is we've got to get that data quality, that correlation between R and G near zero. To start with, it's got to be near zero to start with. You got to have not too much of this bias to start with. And you can work on reducing that if you have good correlates. And so with electronic health records, there's, when you're looking at health, what are some of the good correlates that might be out there? Race, income, education, sex, having health insurance, age. Those are things we know are correlated with a lot of health conditions. So that's the question that CDC posted, which was, look at the EHR data sources and what could we do to try and improve on the estimates that we currently have from like BRFSS, the Behavioral Risk Factor Surveillance System. All of the EHRs have sex or gender and age possibly grouped together. Market Scan is one that has millions of participants but does not have any race, income, education data. It does have an urban metro status variable on it. Dartnet has over 1 million participants. Race is missing 9% of the time. It does not have income or education. Without that, it's really hard to impute for the missing 9% and know what to do with race. IQVia is kind of the one getting lots of publicity lately, has multiple millions of participants. Race is missing 13% of the time, and in race that's recorded, less than 1% are Hispanic. Raises all kinds of questions. There's no income or education available on it. And then there's all of us. So all of us is, you may remember, about 20 years ago in the early 2000s, the U.S. government planned to collect big health data from a nationally representative sample of 100,000 people, and Jennifer's shaking her head. We won't go into all your personal connections to this. It was the National Children's Survey, and the idea was to collect for a representative sample from in utero to age 21, and it was going to be hard and expensive, but it was definitely doable. Government had figured out how to do it, but NIH canceled it just as it was getting going, and they repositioned the money to create All of Us. And the idea here was, rather than 100,000, we're going to get 1 million Americans to provide health data, get access to their electronic health records. But beyond that, we're going to have them fill out a questionnaire, giving us all their socioeconomic, demographic information, including race and income. Now, income's missing 22% of the time there, but we have education, age, sex. We have a lot of information from which you can do a pretty good job of imputing the missing income. They also getting blood samples so they can get genotypes and all of that. I mean, this is a really rich data set, potentially. So we tried weighting the All of Us data to try and reduce the bias to be able to produce state-level estimates. And we used age, race, sex, education, health insurance, income, all from that socioeconomic demographic questionnaire that they have for people. And the folks I was working with at Georgia Tech wrote a nice Python program that not only looked at if you just used the marginals, but if you looked at all the two-way interaction terms and try and minimize the weighting issues, because we know if you have very differential weights, you can adversely impact the accuracy of the estimates. And that's why sex and education, we ended up collapsing. If a state had less than 1,000, because while they want to get 1 million, they currently have a little over, or 2022, they had a little over 300,000 participants so far, and a little less than 300,000 of them have any of the EHR health visit data so far with them. So if they have more than 1,000, we can do that weighting by state. If it was less than 1,000, we collapsed to the census division and took all of the participants in that division and reweighted them to each state. So that's really the equivalent of the synthetic estimator, the first small area estimate that was introduced by NCHS in 1968, except you're using a division average rather than national average that they used back then. And I know you can improve upon that by using the actual few cases from a state, but that's really a minimal issue in what we're talking about here, so we left that simple to focus on what's going on. And so the example we're using is looking at diabetes, trying to estimate whether or not you have diabetes. BRFSS collects over 1,000 interviews every year in each state with adults, and it provides the best estimate. You're asking people, has a health provider ever told you you have diabetes? So that's the part of diabetes you're getting with it. The sample is unbiased. There is significant non-response. And in their weighting, they don't adjust for income. So there are places where bias can get in there in that. And the question is, can we do better? And BRFSS is at the state level, so we're going to try and get diabetes at the state level. And then we're also going to look at things that BRFSS can't do. Because with the health records, we can look and see whether their diabetes is under control or not. So to do this from the health records, we have to define who has diabetes. So another NCHS-funded project called Supreme DM has a definition of diabetes that we used, which basically says, have you been diagnosed? Are you taking one of the medications that basically only people with diabetes take, even if they haven't bothered to tell you or you don't remember that they told you you have diabetes? Or do you have at least two measurements where you have your A1C is above 6.5, that's your hemoglobin level, or your fasting plasma glucose is greater than 126. If that's happened on two distinct times, then we're going to say you have diabetes. So that definition is a little bit bigger than what BRFSS does, which just says, has anybody told you? So we expect the numbers to be a bit higher. And this is what we get. The kind of mustardy yellow color are the BRFSS estimates, the states ordered by their BRFSS estimates from smallest to largest. And the blue are the all of us estimates. So as we expect, they're a little bit higher than BRFSS. As we were hoping, they kind of go up from bottom left to top right, following along with BRFSS. The states that survey says have higher rates of diabetes are the ones that we're getting being higher as well. So in general, that looks good. But there are a couple outliers. First one is down here, the bottom right. This is the state of Louisiana. And when we looked into it, we found that only 14% of the people in Louisiana who had electronic health records of a visit have been diagnosed with anything. Nationally, it was 60% of the people had been diagnosed with something. Not necessarily diabetes, it might be hypertension, I don't know, bad breath, just some diagnosis. And every state other than Louisiana had at least 36% of them have it, but Louisiana only 14%. So this is the kind of the first warning sign. You have a single source of electronic health records, but that doesn't mean the underlying data are of consistent quality, because who knows the different healthcare practices that they had to negotiate with and what got provided. So Louisiana's data doesn't seem comparable to anybody else's. The other problem is up on the top left. There's a bunch of states here whose diabetes estimates seem really high, over 25%, when BRFSS says it's only about 10% for them. It turns out these are New England states. And in New England, the EHR data on all of us comes from basically Massachusetts and Connecticut. The other four states hardly have any, and Massachusetts is almost all of the data. So basically it's Massachusetts, and then just different age, sex, race distributions for the other states come up with slightly different estimates. Now, I want to give all of us very strong kudos for recognizing that historically in a lot of big data sets, minority populations, poor people have been underrepresented. And we know this has led to bad health outcomes. So they have made conscious efforts to reach out and get these groups that would not otherwise be included. It appears that in Massachusetts, at least, they have gone overboard. It could be that they actually reached out to groups that helped the population with diabetes and got them to be in their sample. And there aren't enough other people in it. so that even after you have adjusted for age and sex and income and and race and all of this, the estimates are just unbelievably large in Massachusetts, and that's going to the other. So what we've seen here is you can get lots of good estimates, but not everywhere. And you're going to have to be cautious, and you have to look at it. So let's look at how important each of the variables that we used are. So what we have here are the weighting variables that were used, and let's see, if I move back, the cursor does not show up. All the way on the left is age, and you can see it's really dependent on age. As you get older, much higher chance of having diabetes. The next two columns is sex. It's not all that important directly. Then insurance, much higher rate for the people who have insurance than the people without insurance. The third column says missing. The last column in each of these is kind of missing. The next, in the middle, you have race, and there's a big difference between the Asian population and the non-Hispanic white and black population in their incidence levels. And then we have education, and it goes down as you're more educated. Income goes down, but not quite as much. But remember, we actually used an interaction of sex with education. And you can see that here. On the left, we have for females, and it drops much more. In fact, for females, when you go from not having graduated high school to graduating college, the diabetes rate goes from 22% down to 12%. But for males on the right, it's only from 19 to 16. So it's a much steeper impact, and that's what's being picked up by having this interaction term. Let me take two slides to quickly point out a real nice thing about electronic health records. We can get at control, which we can't in BRFSS, because this is, you have to know what your A1C reading is now to have glycemic control. So the definition of it is if your A1C is under 7, and everybody can all of a sudden probably hear down with Rybelsus going through their head, or Ozempic trizone. We're inundated with these commercials about getting your A1C down less than 7. The only estimate that CDC puts out is NHANES has a national estimate of 50.5%. So half the people who have diabetes have it under control, but no state estimates. But we can look at the data we have for each state, and we can look at when they were first diagnosed or first had medicine, whatever caused them to be considered diabetes, and we look at their most recent A1C since then. If it's less than 7, they're in control. If it's not, out of control. And then if they don't have any A1C reading, then it's indeterminate. We don't know. Some of them are probably in control. And get this, the light blue are people in control. This is states ordered by the percent in control. The purple is this indeterminate, and the green is out of control. And you can see a lot of differentiation. All the way on the left, Massachusetts has over 60% in control. And of course, some of the indeterminates are also, so it's even a higher number. And most of the way to the right, you only have around a third of them in control in places like Utah. So you can differentiate compared to that 50% number across the country that NHANES gives you. But again, we run into some problems. Notice the 7 states on the right here. It's all indeterminate. This is the whole west, north, central, the upper Great Plains. Every person who has diabetes in the data set did not have an A1C reading since they were diagnosed. So we can't do it. So again, can't get it for every state, but EHRs do provide that kind of insight. So the question is, can we do this kind of thing, not with all of us, but with these much larger sources with millions of people in them, like IQVia? But as we said, race is missing. Generally, they only have people with health insurance, no income or education. So you're stuck with only age and sex. So to mimic that, we went and we redid the weighting of all of us just using age and sex. to say how much of the bias that we got rid of with all of these variables is going to still be in there if we tried to just do it with age and sex. So you recognize this picture. This is almost the same. This is with the new weighting because of the wonders of graphics. Now BRFSS is in blue and all of us is in green. But we still have Louisiana down here. Nothing helps with it. We still have up on the top left the New England. But we have lots of changes. 31 out of the 51 states, since we're here at Mathematica, we count DC as a state. 31 out of the 51 changed by over 1%. Again, not relative percent, by more than 1%. Connecticut's estimate changed by almost 10%. And South Carolina's by over 5%. So you get some really different numbers. Also, these green dots don't have that bottom left to top right kind of pattern. There's just not that much variation between the states. Across the bottom, the question was the two axes. Across the bottom is the state number. They're ordered by BRFSS. And then going up is the percent that have diabetes. Thank you. I should have clarified that. All right. Again, let's take a look at the impact of, again, we only had age and sex. Age, you can see, is very important. Sex doesn't appear to be all that important. But we use the interaction term here. And if you compare the purple with the dark green, the two right-hand sides, you'll see that for females, the diabetes estimate is higher for every group until you get to 70 plus, and it flips. So that's, again, why the interaction term was important. But there's a really interesting finding here. I said that sex didn't seem to have all that much of an impact. But I've circled it here because in this simple model, you get that females are more likely to have diabetes than males. If I go back and show you again the slide from before with the full model, females have a lower percentage than males. In the full model, females are 16%, males 16.7%. So when you control for age and health insurance and race and income, you see that females are less likely. In the second model, when you don't control for as many sources of potential bias, you get that females are more likely. And these are both, we're talking about a sample of 300,000, of whom about half are males and half are females. These are statistically significant differences if you were writing a paper and getting it published. And you would reverse the comment about whether men or women are more likely to have diabetes, depending upon whether or not you controlled for these other sources. So I really hope that gets you to be hesitant about what happens if we are not able to control for these sources. Okay. So let me just summarize the findings. Big data give you lots of information, but the biases can swamp the reduction in sampling error. If it's not a probability sample, even a small correlation between response propensity and the variable of interest can destroy the accuracy. And remember, it was 0.006 was the correlation, or 0.007 on that Facebook data that we looked at. When using big data, it's important to minimize the correlation through weighting, propensity score modeling, multiple regression, post-stratification. All of those have this exact same problem because they need these variables to do the models. So this is not something that, oh, I don't do weighting, I do propensity score modeling. That's not going to help you. So you have the same limitations. And you can produce state-level estimates from electronic health records. They may be inconsistent from state to state. Some of those individual states may be of poor quality. But the EHRs do allow you to go in depth, go beyond just what does the respondent actually know to get at things like control. at the state level. And finally, this warning that simplistic models, when you don't have a good set of explanatory variables of socioeconomic, demographic variables, can produce really quite misleading estimates. So beware. Thank you.
Is this loud enough? All right. Well, thank you all for coming. I'm Jennifer Parker, the director of the Division of Research and Methodology at the National Center for Health Statistics, which is located, for those of you who don't know, the inner workings of the Health and Human Services Department within CDC, as David looked at me when he was showing COVID estimates, which I will say happened down in Atlanta, not in Hyattsville. Which isn't to say that we aren't quite interested in those data, as well as EHRs. And so thank you to Aaron for inviting me to be part of this President's Invited session today. I'm really happy to be here. So when thinking about this presentation, David's presentation, and what I can add to this without going overboard. This is a discussion after all. I thought what I would do is take some of the ideas that David talked about when talking about electronic health records in particular, and put them in the context of the FCSM's recent framework for data quality. This came out in 2020 for those of you who missed it, and it was based on a lot of work done and presented here at WSS in various workshops a few years ago. But essentially, the framework that the FCSM put forward thinks about data quality from a larger perspective. Utility, objectivity, integrity. So are the data relevant for what they're going to be used for? Are the data objective? And by that we mean accurate and coherent. And were the data collected and used protected with scientific integrity, or with integrity, including scientific integrity in the processing, but also free from interference, things like that. And importantly, the framework is designed to assess quality from the perspective of fitness for use or fitness for purpose. So are the data that you're looking at useful for what you're going to use them for, not necessarily for their original purpose? And so when we think about fitness for purpose and we think about electronic health records, well, their original purpose is really to monitor your health between you and your physician, right, and your medical insurance and things like that. But really, that's the original purpose. And then when we think about using them for research, that's a different purpose. And so the quality for one purpose may not be the same as the quality for another purpose. And the other thing we think about is, in that framework, even though there's 11 dimensions within 3 domains, but we know that not all of those dimensions are going to be equally important for each purpose. And David rightly was talking about accuracy, bias, all of those things that make the data less accurate and not give you the right state estimate for Louisiana for a variety of reasons, or that affect the variability and how can we measure these things. And the framework also talks about blended data. And so when you think about blended data, and in this case, what I'm thinking about is we're combining the data from all of us, which is a sample of people, not a group of volunteers who are participating in this wonderful program at NIH. That's one set of data. You're collecting the surveys from them and getting the genetic information. And then we're combining that with their electronic health records, which is a different source of data. And so the quality of that combined data is based on the quality of the input sources, the quality of the blending method, how they're put together or linked, and the quality of the output sources. And so when I looked at David's slides, you know, I distilled it down to, you know, for the purpose that we're interested in, specifically, are we calculating state estimates for diabetes with this blended data? And we've been focused on the dimension accuracy. I said that before. So when we look at this dimension of accuracy, what David rightly put forward for the EHRs, we know some of the, you know, the framework uses language like threats to quality, you know, what types of things can threaten the quality, and what kind of mitigations can offset some of those threats. And so when we think of some of the threats to accuracy for the EHRs, you know, they're not nationally representative, they're not even state representative, and there's state-to-state inconsistencies. There, as David pointed out, the information needed to do a good job with weighting may not be there in terms of you know, all the factors that affect, you know, the propensity to be in a record, or the propensity, or the outcomes. And the EHR systems are far from mature. I wouldn't even say not all fully mature. They're far from mature. You know, when a group of us were looking at these dimension, you know, the framework for a different sort of data, what we really realized was that subject matter experts are really needed to understand the data quality of these input sources, particularly when we're blending. And if we had a group of physicians in this room, I'm sure that that quality of the threats to data quality for EHRs would go on slide after slide after slide. But we don't. We're a group of statisticians. And what we see is that despite all of those limitations, these EHRs have a lot of information that we're not going to get from our surveys, we're not going to get from other sources. You know, all that lab data for, you know, the A1C levels and other tests like that. You know, they've got the, you know, X-rays, and they've got other screening, other scans like that. They've got doctor's impressions, you know, so you might not be tested for diabetes on that the visit that you're going in for, but all that information, you know, if the physician thinks it's relevant for the visit you're going in for, you know, that's going to be part of that. And so that's really great. And the sample sizes are huge, you know, despite the shrinkage that David talked about. And I wrote here that the inclusion in the EHRs is related to access to care, type of insurance, and other factors. I know that when my children were young adults, after the age of 26, when I stopped paying for their health insurance, you know, they bounced around, you know, from place to place. And, you know, all these different insurance companies had different systems. So, you know, I expect that would affect your ability to capture some of that. But then, yeah, I also thought about the all of us sample, you know, a large sample of volunteers, some targeted recruitment, and a lot of potential for the data, the detailed information that the all of us sample is getting. But I really have no idea who signs up for all of us. I actually read more about it after reading David's slides, and I thought, well, maybe I should sign up, you know. It looked really interesting, but I have no idea who signs up for that. And I think for the purposes of all of us, the blending method is just a simple linkage, so I skipped over that. But, you know, when you think about the output data, the data that David was using to get these state estimates, do we really need to think about bias mitigations for each source separately, or should we put them together? Like, you know, David said that, I think, what did you say, 80% of the people had electronic health records who were in all of us, something around that number. And, you know, do we need to think about those sources? You know, what are the intersections of that? You know, in this case, I think you did the right thing in terms of doing the weighting with the combined data, and rather than trying to do it separately and putting it together. And we did see that with the combined source of data, we actually have a lot more information for weighting. So even though we might be able to use electronic health records from another source for state estimates, but when we combine with all of us, we actually get better estimates, perhaps, because of the ability to use more information for weighting. And I glossed over some of these other dimensions of data quality, But in terms of timeliness, one of the reasons we're doing this is, when we think about big data and electronic health records is because the data might be faster than CDC and other sources of official estimates. And the fact that we're considering it means that we think it might be relevant for the purpose that we're going to be putting it towards. The large sample size gives us a perception of granularity. With 250,000 Facebook people, chances are there were some pockets of people in that group that we could have pulled out that we might not see. They might not have appeared at all. I don't know how that affects the effective sample sizes for those groups. I expect those calculations would be a little bit different. But we think about accessibility. How can we get the data? I think all of us might be trying to get other health records from people. How are they going to do that? Are the data accessible? Will they be able to get it? And use it with appropriate integrity of confidentiality methodology. But then I thought about it a little bit more and came up with some questions for David, but also for the rest of the audience. When we think about electronic health records and blending it, we saw, some of the biases with the state level estimates, but what about other purposes? What if we were trying to understand state trends within states, not levels, and so you don't have to get the level right, but if you're looking over time, would you actually get like increases in diabetes or decreases in diabetes? Would you actually be able to capture that? Maybe, maybe not. What if you were looking at within state disparities? If you were looking at diabetes levels for, say, African American adults versus white adults, would the state level data be able to capture that, even if the levels might not be right? I wrote down, I put down here uninsured or underinsured people. I think that's going to be a hard one with some of these electronic health. Other health endpoints. This is a question that I'm really interested in because, a lot of times when we're assessing data quality and before we want to use it, we think it might be relevant and we have some of these endpoints we want to look at. Can we come up with can we as statisticians come up with rules of thumb? Are there ways we can measure proxies, simulate things, where we can understand whether, asthma might be a good candidate for electronic health records, but, maybe birth control use might not be, or something like that, where we think about classes of variables where we can think about this a priori for different endpoints. And again, if I focused on accuracy, if data aren't accurate, they might not be relevant. So I think that's fine for this. But really, these were some of the questions I thought of. Turning it back to where I sit, we are at NCHS obviously very interested in electronic health records. We have our healthcare surveys, which are using electronic health records for some of their purposes. But we're also, we also think about what would we do if we could get the healthcare record, the electronic health records for some of our survey participants, notwithstanding, all of the consent and logistical issues, but what would that mean? Our large surveys are more representative, so if we combined electronic health records with the National Health Interview Survey, for example, it would be more representative than all of us. We would have more variables for weighting. We would have a smaller sample size. Our large national surveys, with the exception of, the American Community Survey is very large, but our surveys aren't that large. How does survey non-response and item non-response fit in with the electronic health records and the biases with those? I'm sorry, but I'm done. So what I was going to do is turn it back over to David to think about some of these issues that I was just talking about, which I'm sorry I'm too quiet, but, again, other purposes for electronic health records. and what the work that he's been doing with CDC and others with electronic health records and understanding those biases. How would it work for other questions? And with that, I'm going to turn it over to you. Oh, one thing. I can't stop without, how do I get past? Without the disclaimer. I know this is being recorded, so I just want to say out loud that my remarks are mine alone and not those of CDC or NCHS. So thank you very much.
I think I'll do it this way to make sure that people can hear. But this one seems to echo to me. I don't know. And it won't echo? Okay. So thank you for those comments, and in particular, bringing out the idea of the quality frameworks. How many of you here have worked with or reviewed either the FCFM quality framework or Stat Canada or UN or European, any of those? I would encourage people to do that. There's an article I wrote in 2017, I think, the Statistical Journal of the IAOS, that compares a whole bunch of the frameworks. It doesn't have this one because it's newer, but they have a lot of similarities, and they raise some good points because we tend to over-focus on accuracy. There are times when accuracy is not the most important. There are times where timeliness is the most important. As in the COVID example back then, it's really nice to know now how accurate or inaccurate they were, but policymakers needed information right away. And we now know that rather than listening to Facebook, we should have been listening to Ipsos. I mean, that's helpful, but sometimes there are things that override it. The coherence of how it fits in with all the other data. You know, these can all be very, very important. So I like that you brought that up. One other thing you made a point that's really good, that just because there are biases in the mean doesn't necessarily mean there are biases in the trend. I don't know, there might be, because as the data keeps growing, they're bringing in other groups. So think about the Massachusetts example where 25% of the people have diabetes. Well, if they start bringing in people from the rest of the state who aren't focused on diabetes, that number is going to go down. But is it going down because diabetes is going down in Massachusetts, or is it because the data becoming more representative? And it's a complicated questions to deal with. Anyway, with that, I'd love to turn it over to Erin. Are you going to lead the Q&A?
I am John Aboud. For 6 years, I had the same job Jennifer has at the Census Bureau. I stopped in October. I'm retiring at the end of June. So, David, I want to take you basically back to the dilemma that Jennifer posed on her last slide and ask the question somewhat more directly. So, Xiao-Li's effective in assumes that you actually could conduct a simple random sample with no unit non-response, no item non-response, and tabulate it in a timely fashion. And for those of us who labor in that field, it's been a very, very long time since we could even do 1,000 units that way. And one of the things that big data open the possibility for is making our surveys, the American Community Survey is between $230 and $250 million a year, depending on the year that you look at. That's actually expensive, but for the amount of information it generates, not particularly expensive. So it reports an APOR-R4 response rate that is not 90% anymore, but it's between 80 and 90%. That hides the fact that I'm just going to say a very large fraction because I'm not sure the number that I know has ever been cleared for release. A very large fraction of the sampled addresses didn't respond. And what we learned from the 2020 ACS, because there was 6 months of interrupted field work that simply couldn't be redone, right? That was that those non-responses don't look like the responses. And that's generically true for the ACS. The non-responding addresses do not look like the responding addresses, but the accuracy associated with that APOR-R4 response rate assumes that the ignorable missing data assumption holds, and all the edit and imputation that went into that number got you an unbiased estimate. On the other hand, a lot of these big data do relate to those addresses, and address linkage is not such high tech that you have to have pretty sophisticated systems to use it. What the statistical agencies have that you don't have with the EHR is a reliable, high-cost frame to do that kind of repair with. So I'm wondering if you've thought about the issue of how to make things like EHR, or all of us, work better if we use different statistical tools. Instead of trying to adjust the weights, we try to discover the non-representativeness of the people who aren't in the sample.
It's a really good question. I guess it's
Thought about your whole talk.
I think it's probably analogous to how the census has always looked at trying to determine if a vacant house is has somebody living there, or is whether it's truly vacant or it's a non-response to the census. And you've always used community level information. Yeah, Tom. So it's a really interesting idea of whether EHRs could help us undo the bias that comes into or from non-response and things like that in our surveys. I'm actually, I think, more comfortable imagining that than trying to use the EHRs by themselves. I think this record linkage is a neat idea. I worry that people oversell how accurately we can link things. It could be that behind the curtain of what census has access to, you can do a really good job, but for the rest of us, it could be really problematic. So it's a really good question. It's going to have the same problems, though, that the quality in Louisiana of the EHR data may be much worse than in these other places, and we're not going to get around that. I think somehow we have to put pressure on the organizers of the EHRs, just like in non-health settings, the other big data sources, to really focus on what we think of as the weighting variables, that they have to attach those to the extent they possibly can.
I just want to follow up. The quote that you gave from Jeremy Wu was based on an administrative data set that I happen to be extraordinarily familiar with. And when it was at 80%, the reason why it wasn't as good as a 5% simple random sample is that we knew what states were missing, and we knew that there were things that happened in those states that were not well represented by the others. When those states came in and it got a little closer to 85%, then it was very easy to demonstrate that that weighting corrections took you all the way to high statistical efficiency. Those are the sorts. I think that's basically exactly what you just concluded. That if we work harder to know what it is about the missing people that we're not covering properly in those found data sets, I actually like that term, we might do a better job of integrating them into our information system. Well, thank you for your talk.
Hi, I'm Susan Paddock from NORC. I just want to thank you, David, for your talk, and thank you, Jennifer, for your discussion. I had a couple comments about the COVID-19 results, and I was a few minutes late, so I hope I didn't miss this. But you know, one I guess other sort of factor with the Axios Ipsos data was that it was it came from the knowledge panel, which is an ABS probability sample, and so that is likely another reason why it looked like the bias was near zero relative to the CDC, I think, quote unquote truth that was presented in the paper. And the other sort of question and to your point about the trends, I think that's an area that is getting a lot of attention now. And I just wanted to mention, I saw recently Walter Dempsey at Michigan has a paper out looking at this issue of COVID-19 trends and showing that the information about the trends is certainly a lot more reliable than the information about the point estimates. So I think it's really interesting to see some of that work as well come out. I guess final question I have, just thinking about the all of us graph and versus the BRFSS data, is just, you know, at some point, I guess there's like an operational question of when do you go ahead and use the all of us or whatever versus the survey, and just thinking about, do you create the survey and sort of fill in the blanks, if you will, with the found data, or take the found data and fill in the blanks with the survey, and, you know, just kind of wondering if you have thoughts on that issue. So anyway, thank you.
All right, so there's three things there. Thank you for the questions. The fact that it's an ABS, address-based sample, so higher quality web-based panel than, for example, what Facebook was doing. I guess that's probably how they had the level of geographic adjustments that they were able to do in the weighting that the others didn't. So that was important. Nice to get a plug for ABS samples. The second one about the trends, I guess what I see from this data is I'd be leery on measuring the trends and its accuracy in the same way, but for a different reason. But the same way here, I said, overall, you can get lots of nice state data, but there are certain ones that I wouldn't trust at all. I wouldn't use those New England data. I wouldn't use the Louisiana data that I showed you. For the rest of the states, you probably could get pretty nice trend estimates with all of us. But again, for like Massachusetts, its trend data, I wouldn't trust at all, because in all likelihood, I hope, it's that their sample's getting more representative. And I don't know how much of the trend is from that versus the actual changes in diabetes rates in Massachusetts. So this fact that these big data sets are really combinations of lots of other big data sets, right? That's even true with housing characteristics that you get from local governments, right? They're combining different data sources, and how they do it in one state might be very different from how they do it in another state. And we treat them as an administrative data source, and there are really many of them that are confounded. What was the third point?
I was just thinking about, I mean, just the use of multiple data sources, and at some point in the decision will, need to be made about, do we go with the found data, or do we go with the survey data, and just thinking about how to think about that. I think that the data quality framework is useful, but I'm just kind of curious if there are sort of additional considerations or comments that could be made about that.
Yeah, so let's compare the two things I showed, the diabetes level versus the diabetes being under control. So diabetes under control is something that our surveys, other than in Haynes, just can't get to. And Haynes does it because it actually takes a random sample and does all the physical exams. So it's much better than the EHR kinds of data, because the likelihood that you have an A1C reading there is highly correlated with whether or not you have diabetes or how long you've had diabetes. So when we don't have an alternative, like under control, then it's great to use the EHR, but I think we probably want to use where it overlaps with the surveys as a kind of control to say, do we trust these data or not? The highest level under control were Massachusetts and the states around Massachusetts, but I know that it's got this big overestimate of diabetes. Does it have an unrepresentative set of people with diabetes? That I don't know. So if it's got a lot of them, but they represent the population with diabetes, then the control data are great. But if it's got people who not only have diabetes, but are part of a program that's treating diabetes, and that's how they reached out to them, then it's probably a really biased sample of the people with diabetes. So I think you still need the survey as a question and caution sign when you're using the EHRs.
So we have a question online that's asking, can you talk more about the concept of the law of large populations? Does this provide an upper bound for an estimate when taking into account the representativeness or non-representativeness of a sample?
First of all, that's not a part where I'm particularly expert on, but from the reading that I have done, what it is just like a flashing bright orange caution light with big data, that just because you have large samples, it doesn't have to be useful. And it's much worse than you think. Could be much worse than you think. Thank you. Thank you. And so that's it, because again, our training was all about sigma. It was all about the standard deviation and then the standard error of the estimate and looking at the variance, confidence intervals based on the variance. It's a strange enough experience to try and do a confidence interval that in some way reflects bias. So if you're combining data sources, whether it's small area estimation or these purposes, to instead of doing inverse square root of the variance weighting using square root of the mean square error, we have to try and get some estimate of the bias to incorporate in there. And that's what this is warning us about.
Hi, thank you so much, David, for the talk. I really enjoyed it. My name's Nadia. I'm from Mathematica. I just have a quick question about the MA data in the Northeast. So were you saying that because Massachusetts and Connecticut had a lot of data that influenced like the whole Northeast estimates being higher, or that particularly those two states were just had high incidence?
Okay. Apologize if it wasn't clear. So in that region, that division, 4 of the states had very little data, well under 1,000. You know, Massachusetts, Vermont, New Hampshire, and Rhode Island. Connecticut had, if I remember right, like 2,000 cases, plenty to make an estimate. But Massachusetts had like 20,000 cases. So when for the other 4 states, when you take all of the data from New England, you have 22,000 cases, but 90% of them are coming from Massachusetts. So it was the Massachusetts data that was really driving. That's why in that oval, you had 5 data points. The Connecticut data was actually a little bit lower. But then again, remember when we dropped out all but age and sex, it was Connecticut that jumped up 10 points. So it went from like 12% to 22% with diabetes. crazy difference. But so that was the issue, that it really came down to what was going on in Massachusetts, right there.
Okay, thanks.
Thank you very much. My name's Dan Vroom. My area of work is more in business and economic statistics, so I'm in a slightly different domain, as they say. But one thing was sort of occurring to me is, what really is the difference between a simple random sample and a big data sample? To me, the one is just a larger scale or order of magnitude of underlying data than the former.
Okay.
So in other words, is it a difference without a distinction?
No, it is not. And this is true whether it's a business survey or not, or a health survey, that in a simple random sample or a stratified random sample, the kinds that the government agencies are typically doing, they have characteristics of all of the people in the whole population, or at least in their sampling frame, which is most of the population. And they're able to select a random group of them, and they're not all going to respond, but the ones who don't respond, they know things about, so they can adjust and let others who had similar characteristics represent them. In these big data sources that were not designed as surveys to measure this, we don't know who the non-respondents are. And as a result, we have no idea whether we've gotten 10 times as many people with diabetes to respond or not, or poor people, or black people. So in an earlier research, we tried using market scan with NHANES and National Health Interview Survey, and the market scan didn't have race. So what we did to try and estimate, but it was a very large sample, to try and estimate how biased might it be, we said, okay, let's look at how different the rates were for on NHANES or NHIS, I can't remember which, for different races, for blacks, for whites, for Hispanics. And then we said, so if this market scan file happens to be 90% whites, how far off is it going to be? Or if it was 90% black people who are in the data file, how far off might it be? So we could try and do a sensitivity analysis, get an approximate bias of what might be there, and add that on. In theory, with a simple random sample, with a well-designed sample survey, you can minimize tremendously those biases. So that's where the big difference comes in.
Thank you.
Yeah. With business surveys, you can think about, if you didn't know the measure of size, you just know that you have 100,000 businesses that responded, but you don't know if the National Small Business Association got all of their members to respond, or if you got General Motors and Amazon and in there and where they are, you would get very different estimates.
We have time for one more question, and it's going to come from an online audience member. Is it true that we need to determine the best reference data source when harmonizing the measurements of, for example, diseases across surveys? How important should the validity process be? Is it true that we need to determine the best reference data source when harmonizing measurements of various surveys, such as diseases across surveys? How important should the validity process be?
Interesting question, and I think I know what you're getting at. And what I want to pick up on is the analogy in that question with, if you've read any history of statistics, that up until, I don't know if it was maybe Galton and people around his time, when there would be multiple measurements, they would try and figure out which was the best measurement. So we were in Ecuador a few years ago, and they have this big monument on the equator, although it turns out it's actually about 100 meters off from the equator. But it's there because Europeans sent people to various parts of the world to measure like transects of mercury across the sun to get different estimates. And they would then say which one was most valid, which was best, and they would take that. And the statistical contribution to science was to say, no, you want to average these guys, but if some are better than others, you want to include them with higher weight in the average. That wasn't the original thing. That was more by the time you get to Pearson and Fisher 120 or so years ago. So I think the same thing applies here. When we have multiple data sets, it's not which one is best. They all probably have strengths and weaknesses, and it's really important to go to, as Jennifer said, these frameworks and think about all the different components that make up quality. And then figure out how to try and weight them based on their overall quality. And one of the lessons from this is that doesn't mean variance. It means kind of mean square error, but it's also, timeliness, right? If you have one data set that's quite accurate from 5 years ago, and then you have one that's not quite as accurate from 2 years ago, you have to balance how much that time difference means to you compared to standard errors. So you have to think about all of the different components and figure out how to combine them.
Folks, that is the end of today's President's Invited talk. I encourage you to speak with the main author as well as the discussant in our reception to follow. For those of you online or in person who were not here at the beginning, just a reminder that our next event is June 21st, where Rebecca Hubbard will give the Cox lecture, followed by our annual dinner. And then we also have the review planned in July 28th. So thank you so much for attending, and thank you so much to David and Jennifer. Let's give a round of applause for them. All right, let's eat.
You've been on